Just this week, the Centers for Disease Control and Prevention issued some new guidelines regarding prescribing opioid painkillers. That's because the CDC says the risks from the drugs outweigh the benefits for almost everybody. And now doctors are being recommended to prescribe the lowest dose possible for patients for the shortest amount of time. To talk more about this, because there is some controversy, I'm happy to welcome back to the show Dr. Craig Allen. He's the medical director at Rushford Center, here to talk more. Thank you for being here again.
Thanks for having me, Tim.
And yeah, there's so much to talk about. Maybe we should just start with some definitions, start with the exceptions. Now, they're saying this applies to almost everybody, but not everybody.
That's right. This does not apply to people who are being treated for cancer and for palliative care, end-of-life care. This is not involving those folks.
So this is for people who are in chronic pain.
Chronic pain. So more than 3 months they've been experiencing pain. That's the group that this focuses on, these guidelines from the CDC.
Now, my first question said, okay, if the recommendations are the shortest amount of medication for the shortest amount of time, or the smallest amount of medication for the shortest amount of time, isn't that the rule of thumb they should be following for all medications in the first place?
Yeah, I think that these guidelines reinforce good practice and they reinforce good medicine. So you want to, as a physician, you want to make sure that you have tried other strategies, and actually the most accepted strategies for chronic pain are non-opioid medications, so non-opioid interventions. There are other medications that are non-opioid, non-addictive. There are other strategies like cognitive behavioral therapy. There's physical interventions, exercise, physical therapy that don't involve the opioids and don't involve the risks of the opioids.
Let's talk about the risks of the opioids. We talk so much about heroin overdoses. How are these linked in with that, and how are they a problem on their own as prescription drug abuse?
Yeah, so 40 people die a day from opioid-related overdose deaths. So there's the risk of dying, and people aren't aware of the potential of that medication. So this is a big gun medication, and it requires that you educate your patient, let them know what the risks are before you start prescribing it, and then you have to monitor very closely if that's the kind of medication that you and your patient decide that you're going to use. Another very big risk is developing a substance use disorder. And once people have become addicted to opioid analgesics, they can transition to heroin. But even without transitioning to heroin, there's doctor shopping, and there's buying pills on the street. And when that happens, and someone has become addicted, then the doctor needs to be able to identify that and help this person get to a treatment program or a treatment facility that can work with them to get them off of those medications.
Now, when we've talked about this a lot, specifically opioid abuse and even heroin abuse, one of the themes we keep seeing up is that this is happening in every town, this is happening in every socioeconomic class. There's not a typecast person who has a problem with this. Is this sort of a response to that maybe even doctors were looking for the wrong type of people and letting other people get these opioids too much?
Yeah, the group that has the highest rate of opioid overdose death is 45 to 54-year-olds.
Wow.
So, and it affects women disproportionately as well. So doctors may not be thinking of that group, but doctors need to be thinking about the dangers of this medication when they prescribe it to any group. And they need to be thinking about medications like naloxone that can prevent an inadvertent overdose death by giving the Narcan. That's exactly right.
Lastly, why did this, I know that was one part of it, but in general, why did this overprescription problem happen in the first place?
There's a medication that provides immediate relief, although we find out over time, not long-term relief. And there are pharmaceutical companies that want to sell their medication, and there's a lack of understanding, and there's not really good training in medical schools about managing pain or managing addictions, so that if you get a patient who has an addiction, you want to be able to get them to a program. And I want to mention that Rushford has opened up our newest center. We have 7 different centers providing medication-assisted treatment, which is most effective for opioid dependency. And our newest center is opening up in Cheshire next week. However, you have to be able to identify someone who has an addictive disorder in order to get them into treatment. So checking the prescription monitoring website, doing urine toxicology screening, and assessing people for past substance use problems, current psychiatric problems, and risks of past overdose are things that you have to be doing as a doc.
So you remember all that. And again, this does not apply to you if we're talking about end-of-life care, palliative care, or something to help with cancer treatment. Doctor, we do have to run. Thank you so much for being with us. I hope you join us again next time we have to talk about all this.
Thanks.
Coming up next on Good Day Connecticut, we're going to continue to follow breaking news out of Stonington. Crews there are on the scene of a house fire. We will have the latest for you. Stay with us.